You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, new treatment options for people that have hand pain or wrist pain or arm pain. With us, we have a board-certified orthopedic surgeon who specializes in hands. With us, we have Dr. Roger Blauvelt. Dr.
Hi.
Blauvelt, welcome to the program.
Thank you, Randy.
Now, lots of questions here, and we're going to cover a lot of different problems that go on with the hand. But for people that don't know your Cascade Orthopaedics, who's the typical patient and what are the different services you offer?
Well, we're a practice just south of Seattle, and we've been in practice there, not myself, but this group, since the 70s.
Oh, okay.
It's an old group, and we have a group of doctors that are 6 orthopedists and 2 physiatrists. And we take care of all the typical orthopedic subspecialties, starting, with hip and knee surgery, spine surgery, shoulder and knee arthroscopies, foot and ankle surgery, and we have a couple of hand specialists, of which I'm one. So as the hand specialists in the group, the typical patients I see are patients that have problems that may have been ongoing for a period of time. They've been suffering and frustrated with their numbness, with their arthritic pain, with a finger that doesn't move correctly, with their limitations in function and activity. They're losing sleep, they're unhappy, they're having frustrations with work activities, with play activities. They've had to limit themselves as a musician. Hands are really an intimate and huge interface with the world.
You were saying in the green room, you say the hands are a big deal. You use them for everything.
Well, yeah, the hands are your interface with the world, your intimacy, your function, your productivity, everything you do in life, the hands are right in there. And so that people, when they are limited, when they have a disability, when they have symptoms, then all of a sudden their life, there's detractions from their activity, from their enjoyment in life. They lose sleep, they're irritable, their partners are not happy because they're not happy.
Okay.
And you keep your spouse
So it's hard
awake.
to sleep with sore hands, I guess, or numb hands, or
certain
whatever.
conditions. Carpal tunnel, for example, is one where it really disturbs your sleep as one of the primary symptoms.
So let's start with carpal tunnel.
Okay.
I guess, all hand pain is carpal tunnel,
Well,
mostly?
that's the misconception. People come in and they have a hand problem, and what the lay media has portrayed is hand problems are carpal tunnel syndrome.
Okay.
And there's nothing farther from the truth than that. Carpal tunnel is a very specific problem, and it gives a very specific set of symptoms, and it has a very specific set of treatments that can be successful.
So what is the problem then?
So the problem, it's defined by compression of a very important nerve that goes into your hand. The nerves are the communication systems, the data system that carries signals from your hand to your brain. When you touch something, feel something, reach into your pocket, you need that nerve to talk to you.
So it's like one nerve.
One of the main nerves.
Can see it on imaging?
Absolutely.
What's wrong with it?
Well, the nerve goes through a space. It has to get from your neck into your hand. And what it wants to do is be left alone. It wants to just do its job. But it's just like any other wire going through a machine, it can be kinked and it can be disturbed, and that interferes with its function.
So you can see like a kink in or a bent?
Well, literally,
in the
you
nerve?
can, when you do this procedure open and look at the nerve, you can literally see a dent in the nerve in the more severe cases. It's a very simple physical phenomena that's happening to this nerve, and it's very specific, and it gives a specific set of symptoms that can be quite classic. Patients come in, they have numbness in mostly these 4 fingers of their hand.
So it's always numbness with carpal tunnel?
Numbness is the calling card. If you have primarily pain, you could have a number of problems. If you have primarily numbness, there we go.
Oh, okay.
Yeah, so the calling card of numbness, the main ingredient, as I would say, is numbness. So there you are. You're waking up at night, you have numbing pain.
So they feel it at rest?
At
like
rest,
when they're not moving their hand?
That's a great point, because when you're not moving is where it's worse compared to some other things where motion and activity are worse. So things like holding a hairdryer. The ladies, maybe not as much me, will hold the hairdryer for a few minutes, right, to do their thing. And all of a sudden they're finding their hand gets numb and painful, and they have to change their hand. Driving, anything more than 5 or 10 minutes, all of a sudden your hand wants to release the steering wheel and you're frustrated. You have to drive 30 minutes to work every day. You're switching hands 30 times. Gentlemen riding his motorcycle came in the other day. These guys with their hogs, they love it.
These guys get carpal tunnel?
Well, sure. You got to, the carpal tunnel is a middle-aged to older person.
Okay.
And we have a lot of interesting people coming in with the Harley Club, but sitting there holding the motorcycle handle, these guys are on the road for hours. They come in and they're saying, I'm going to the trip from Seattle to the coast or to Sturgis in Dakotas, and that is a long trip to go with carpal tunnel because your hand doesn't like to be in that grip.
Treatable, fixable, reversible?
Yes, we have a number of treatments. When it's mild and people are minimally irritable with it, then you can wear a brace at night and that might control that symptom, and people can go for years when it's mild. When it gets to be more severe, then they escape the relief of that. They're now frustrated because I'm wearing my brace. It used to work, now it's not. That could be a year, that could be 5 years before that progresses. It's a naturally progressive condition. You don't have to do anything to make it worse, but it does progress. Just with age and time, stuff happens. So there you go. You're having more numbness, more pain. You now are awakening despite the brace, and then you come in and see me.
What do you do then? Surgery?
Well, surgery is ultimately a solution, but in many patients, we don't have to resort to that right away.
Okay.
We will get nerve studies to confirm that that's what's going on in most cases. The nerve study will show us whether the nerve is in bad shape and is really asking for help, or if it's in a milder state where we can back off. We can adjust your bracing. We can encourage you to do some home exercises, activity modifications. Injections are an option that can give you time. But
like how much? So if you inject somebody's carpal tunnel, what?
You can give them months of relief.
All right.
Sometimes indefinite. Let's say you're in a period of activity where you are doing a home improvement project and you really crank it up, and then we give you an injection, it quiets it down. It could be years before you're going to have problems again. Pregnancy, interestingly, is a problem.
Is that right? Okay.
That can create carpal tunnel. Now, pregnancy is curable, right? So a young woman who's pregnant comes in with carpal tunnel in her 25th or 30th week. She's got, 5, 10, 15 weeks of misery. We can inject her safely during pregnancy and give her relief. So it depends on the person's scenario. When it is time, when you have exhausted all of those remedies that can be helpful, but it's been years, you've been struggling, and you're just at your wit's end. People come in after years urgently wanting relief because people come to a tipping point and then they're like, it's an emergency. I've had enough. I'm nuts here. I can't go on. So then we can establish what's happening, make sure we have the right diagnosis, and move forward with a surgical treatment. The good news about surgery, everything else is controlling it. Surgery is actually changing your hand and correcting the problem.
Okay, so, and I've seen a little bit of your animation on this. So it's a nerve that kind of is going right here.
Yes, it runs very centrally.
You open up the area to kind of give relief on the nerve?
Well, the carpal tunnel is a tunnel. It is made of bone and ligament. It's a very constrictive conduit, a tube, through which tendons and the nerve go. So when the contents of that tunnel are too plump and too swollen, that happens with age and time, we can then split the roof of the tunnel, like popping open the constricting space, and it relieves the pressure on the nerve.
Now the pain goes away?
What will happen is the nerve symptoms almost turn off like a switch. I've had patients who awaken every night for months, and they'll say the night of surgery was that I slept for the first time, even with a surgical pain.
So the numbness goes away?
The numbness can turn off like a switch. It's quite remarkable.
Nice.
Yes.
So if you could get people early, maybe into their first year of the pain, the numbness.
Yes.
It's a predictable procedure. Like, what is the success rate?
The success rate is very high.
Like 80%?
It's probably over 90% as far as the success in relieving the nerve pain. The trick is to identify the diagnosis correctly. In other words, if you make the right diagnosis, you're going to get a good result.
How many people, like if you had to say in Seattle, how many people have hand pain that could be fixed?
Well,
in your estimation?
All comers, yeah, it's like a lot of things. If you look at carpal tunnel, you can say maybe up to 5% of the adult population has some set of symptoms during some part of their life. And so that's 50,000 out of a million people that are living with carpal tunnel.
Surgery is one of those things in this case that it really helps.
Yeah, it's a tiny little one-stitch operation. Takes less than 10 minutes typically. we don't like to say surgery is no big deal.
You said 3 minutes on the green room.
Well, that's the main part of doing the surgery, but we start, we get ready, we put stitches.
Like 10 minutes.
It's less than 10 minutes of surgery in most cases. So, well, that's great, super, but the key is that it's a simple and reliable thing.
How long does it last? Okay, so you had numbness, you had carpal tunnel. They do like you say, if everything goes right, like a 10-minute surgery. They heal up. Does it come back?
The recurrence rate is very small. It's hard to say, but true recurrence is probably less than 5%.
So you brought a video of the surgery, an animation.
There's a video of the anatomy, and it shows diagrammatically, and then of this endoscopic technique, which is kind of a neat trick where we cut the ligament from the inside.
Okay, good. Well, let's take a look at it. Okay, so what are we looking at?
So you'll see where that nerve runs through the hand and wrist towards the fingers, and it goes above the bones and under that strap, that transverse carpal ligament that forms the roof of the tunnel. So whatever surgery is done, whether with a scope or an open incision, our goal is simply to split that ligament.
So that's all you do, just kind of splitting that up?
You're splitting it and letting it open. It's the analogy I use is you eat too much, you pop your pants open. I'm sure you've never done that, but I have. then you have more turkey at Thanksgiving. So we're just popping the pants open so that nerve can feel better. It's decompressing that space.
Where'd you get your training, by the way?
Started with undergraduate with engineering at Johns Hopkins University in Baltimore, went to medical school at Vanderbilt University in Nashville, and then orthopedic surgical residency in Texas Tech University in Lubbock, Texas, and then a hand fellowship specialty training in Sacramento University of California, Davis Medical Center.
Okay, good. So you've been doing hands for how many years now?
Over 25 years.
Okay, good. And are the results better today than ever before
that
you're seeing?
These endoscopic techniques have made a recovery quicker, right?
Okay.
Just like the laparoscopic procedures and a lot of the minimally invasive surgery, that's in that minimally invasive category. So the minimally invasive is not only smaller scars, but usually a little bit quicker recovery.
Okay, now, and we're short on time. The trigger fingers. What is that? You say it's a big part of
trigger finger is very common.
practice.
For everyone has 2 carpal tunnels, but they have 10 fingers.
Okay.
So more business for me, I suppose. So the deal is a trigger finger occurs when those same tendons that are going through the carpal tunnel, they continue on to your
What is the
finger.
symptoms? What is it?
Yeah, so it's where your fingers are painful and they'll usually catch. The triggering refers to that catching
What do you mean
sensation.
catch? What do you mean catch?
Like a click. Like a snapping.
Closing your fingers and it clicks.
When you grip, your finger will catch and it will often lock in this kind of halfway flexed position. And in early stages, you simply straighten it, sometimes with pain, but then you'll often have to unlock it manually.
Really?
Patients,
is that common?
It is. Yeah, it's equally common to carpal tunnel, arguably.
Interesting.
Yeah, and so patients come in and they'll say when they wake up in the morning, their finger's stiff and it's stuck, and then they'll loosen it up during the day. If they hold a phone for 20 minutes and let go, their finger will catch. It's like gets rusty and stiff and catches. So it's a type of a tendinitis problem where that finger sticks and locks and catches, and one or more fingers can be affected.
You said it's like a pulley system.
Right. So the tendons that run through your finger, there's 2 of them in fingers and 1 in the thumb. In any case, they run through a series of like belt loops, or they're anatomically called pulleys, and they're holding the tendon in place so the tendon does not bowstring.
Like belt loops. Interesting.
Yeah, exactly. It holds it very tightly. It's not loose, it's tight. So whenever that tendon swells, there's a problem. It doesn't fit through the pulleys. And that lump sort of forms into a lump, a swelling. The tendon sort of bunches a little bit. And then as that lump gets through the pulley, it catches. Like a belt with a jewel on it.
So does it just get worse and worse?
Yes,
and then it can stay
usually
down?
does. If patients are particularly stubborn, they'll come in. Last week I did surgery on a big guy. He was a laborer, and he came in and he was walking around like this. I said, "Why are you doing that?" He says, "Well, I can straighten my finger, but then as soon as I move it, it locks again, so I just keep it there." So this guy comes in, it's been weeks. He actually had surgery scheduled for another doctor who fell ill, so he's been delayed, and he comes to see me, and we snuck him in that week, and we released his finger. During surgery, done under a local anesthetic, we literally open up the finger with a small incision.
Yeah.
No fancy instruments needed, 10-minute operation, and we can see where that first of the 5 pulleys is. And by just dividing that pulley, by cutting 1 pulley, you can stop that catching. So during surgery, he showed me, oh, look at that, no catching. We can actually test drive.
Wow.
Yeah, so just like your pants, you can cut one pulley, your pants won't fall down. So we can cut that first pulley, and the tendon works fine. So for this guy recovering from surgery, he'll have a finger that's useful. He'll be able to get back to his work. He drives dump trucks, you know? He's got to climb it out.
I don't think I've ever seen anybody with a locked finger like that.
Well, that's actually an extraordinary case. They usually don't have locked fingers. That's a stubborn person or one who's been delayed, like this fellow, who puts it off, and they can be quite miserable, and they'll finally come in. Usually, if there's enough pain, they'll be coming.
So if somebody's watching this and their fingers like catching every once in a while.
Catching and locking, snapping,
get it done early.
painful.
Do something early.
Yeah, it's really after
sounds routine in a
6
way.
or 8 weeks, you're kind of there.
Okay.
You know, if you're not getting better, if it's not just a temporary thing, you might just be there, and then it's worth treating. But the thing is, surgery isn't necessarily the first option. When someone comes in with a virgin trigger finger, first time, a woman comes in, she has been doing a lot of gardening this summer. She's working out there and noticing that finger's more and more painful.
Okay.
So it's her first trigger finger. We give her an injection. With injections, we have almost, what I tell people is 90% of people get 90% improvement. So that's quite exceptional. The catch is that quite a few do have recurrence. So it's worth a shot, so to speak.
So you start there.
Yeah, yes, avoid surgery. Try to do the least aggressive and invasive thing to make people happy. Right? I'm just a psychiatrist with a knife and a needle. I'm just trying to make people happy.
Do they need a referral to see you? I mean, because I know you get referrals from what? Primary care physicians?
Yeah.
Other orthopedic surgeons?
Absolutely. So,
or can they call you directly?
The referrals are often a function of some insurance thing. Okay. But nowadays there's less gatekeeper type insurance referrals. We'd love to see patients primarily.
So Medicare covers this?
Yes.
Like a workers' comp insurance might cover this?
Absolutely.
Or the right kind of insurance? I mean, you accept insurance.
Primary insurance, yes. You know, we like to take whatever patient's insurance is if we can. And then we want to get them treated. And if you can get them injected that day, within usually days to weeks, their symptoms melt away very nicely.
And it doesn't come back usually for a while?
Well, remember, with injections, you can't have recurrence within that year or so in about 30% of the cases. And that's where the surgery would come in. We can give maybe 2 injections, 3 if you twist my arm a little bit, but when it's coming back and it's that stubborn, it's probably destined to need surgery, because surgery, once again, just like carpal tunnel for trigger finger, gives us a very nice lasting relief.
So it's local, so you numb the area.
We can numb the area.
They could be in and out in 10 minutes.
Give you a little bit of sleepy stuff if you're anxious. Some people they're very anxious. We like to, people have a good surgical experience.
All right.
You know, it's frightening for some. There's a lot of anxiety. You give them a little good stuff, let them drift off, and they're just happy as could be.
Is that right?
Yeah.
And then and the recovery isn't so bad?
Yeah,
on that?
the in and out is very quick. The surgery, once again, about 10 minutes, but in and out an hour or so, and you're back in action within days.
Now, I have questions about arthritis, because you're getting great results with arthritic hands. Is that right?
Yeah.
But first is Dupuytren's. And we are short on time. Am I pronouncing it correctly?
Dupuytren's,
Do
yes.
people with Dupuytren's call it Dupuytren's? Do they know this? And
No.
what is it?
Dupuytren's
what are the symptoms?
is,
First start with symptoms.
so Dupuytren's is a condition. It's, once again, highly genetic, very high genetic pattern. Usually you'll have a brother, uncle, father who has it. It's
What does it look like?
Predominantly male affected. It looks like a finger, unlike a trigger finger which moves and catches. Dupuytren's is not typically painful. What it is a finger that essentially flexes over time, draws down, and does not extend.
Could
no
it be
matter
multiple
what.
fingers? I see a little
It
bit
could
of
be
that going on.
multiple. It's typically the small and ring finger are notoriously affected worse.
Okay.
It occurs with advancing age. I rarely will see it under 40, typically 60 and over. It's mostly Caucasians and mostly men. It can occur in
And
women.
golfers, things like that?
Well, you talk about old white guys, you're talking about fishermen and golfers in my neighborhood.
Okay.
So the guy that I saw last year, he was afraid of surgery, right? He's like, oh, I talked to Joe and they made a big incision in his hand and I'm not doing that. So finally he met one of my patients, right?
Okay.
And he said, all I had was this tiny little procedure and I'm back in action. So he's like, okay, I'll try that. So the treatments have notoriously been big operations, but recent developments in the last 5 or 10 or 15 years have given us very nice minimally invasive treatments. So this guy did the procedure called a needle aponeurotomy. Okay. A lot of big words here, but what it means is you take a very tiny hypodermic needle, like a flu shot, and you use it just through the skin after numbing the hand.
All right.
And you're literally cutting that cord like a guitar pick razor cutting a guitar string. So you pluck away at it and you break that cord that's holding the finger down. It's not the tendon, it's an extra cord of extra stuff that's growing in there. And you can break it and get that finger to release and straighten, literally within minutes. Really? So that's a quick outpatient procedure under a local anesthetic. And what it can do is give people quick relief without the big open incision and the several months of recovery that are needed for that. There's a little bit of pain, but the results are quite remarkable.
Now, you're a surgeon. You had one of these hand surgeries,
right?
With carpal. How soon were you back doing surgery?
With less than 2 weeks.
Really? Okay.
Seeing patients within a week, and well, I'm a hand surgeon, so I'm not slamming in big, implants like a hip surgeon would be. But yeah, you could do surgery within a week or two.
If you have it, you can see. Do you have a bit of a bias? I mean, do you think that, look, you should at least talk to a hand specialist if you've got any one of these problems, just for an opinion?
Yeah, so the truth is that about half of the Dupuytren's patients I see, I just chase away. I say, listen, this is your Dupuytren's. They say, what is this? What is this thing? This cord, this lump in my hand. The doctor says it's a cyst. The doctor says it's a tumor. And I look at it, I say, you know what? This is very typical Dupuytren's. Look, your other hand has a little too. See it? Okay. Don't get excited. Your finger's pretty straight right now. This is the fish you throw back and catch when it gets bigger, because the problem with Dupuytren's, it's progressive.
We have to move on to arthritis. Literally, we have about 2 minutes left. So Dupuytren's, also treatable.
Very treatable.
But get an opinion with a hand specialist. Is that what they call you, by the way?
A hand specialist, yeah. Orthopedic hand specialist, sure.
All right. Now, arthritis. Specifically, the thumb. You say this is where it hurts the most.
The thumb basilar joint, it's a bit of terminology, but it's the base of your thumb. It's a joint you don't look at. It's right there, but it makes your thumb rotate. It does those things that only us primates can do. It's the opposable thumb, right? So it's critical, and there's very little you do with your hand that does not involve using that. So people are painful, they have a deformity, they have swelling, they have weakness. They're usually women more than men, over 40 or 50. It can come in a very early age. 40 is just a youngster, right? So these young women of 40 or so are coming in with moderate to severe arthritis. But of course, most patients are a little older. And grandma, when the kids come at her, she doesn't stick her hand out.
Is that what they tell you?
She's hiding her hand because the little guy is just going to jump on her and give her a big hug, and she'll jerk her hand away with pain. So all the activities of daily living are affected. Everything you're going to do.
Now,
knitting,
for the sake
gardening.
of time, because we only have about a minute and a half. Okay, so you've exhausted all the maybe anti-inflammatory medications, over-the-counter medications, a splint or a brace or something like that. Okay, so they've tried everything, it didn't work. Now it's surgery. So what do you do?
Right. So we can do injections, just interject that. That's a temporary relief. It can buy you time, but ultimately it doesn't change the ultimate result. So surgery, there is a surgery that's been established for many years. It's not new or fancy. It does not use fancy technology. It does not use a synthetic implant. It's all natural. It's all made of you. We basically remove the arthritic joint, leave a space where that thumb joint was, remove a bone that's about the size of a sugar cube, and then in that space, we take a piece of a tendon in your wrist and we make it into a little cushion, and we use that to make the new joint. Then we let the thumb sit in a cast for about 4 weeks and let that new joint kind of integrate. And then when your hand comes out of the cast, your arthritic problem is gone. We've removed it. And you have this new joint. Now, the good news about this surgery is it's almost universally successful. Patients
so it works,
love
like 90+% of the time.
90+%. Most of the doctors I've talked to.
And the pain goes away in the hand.
The pain goes away, patients are functional, and they're like back to good as new. We know this because guess what? She'll come back in 2 years because her other thumb is right behind. And I'll say, how's your right thumb? She's like, oh, it's great. I'm fine, let's go. You know, so we have a lot of data in the literature, and of course plenty of anecdotal data of patients coming in. The best testimony of a procedure working is they come back for number 2.
Okay.
Right?
You know, one of the things you told me on the phone, because I said they have to wear a cast for like a month. You say,
Just
and
a
you
small
compare it
cast.
to like a kitchen remodel.
Right. So it's basically, if you want a kitchen remodel, it's beautiful, but it's a mess and you got to cook in the bathroom for a month. So the downside of the surgery is no one likes having surgery, no one likes being in the cast, and no one likes a period of recovery.
But it works.
But when you're done, you have the new kitchen. You've got your new thumb and you're happy. Your thumb is there. Normal's a hard word, but patients do say, I feel normal, I feel great.
Of everything we've talked about, is arthritis of the hands, of this thumb, is that really common? And it's one of those things that people don't like to do surgery for.
So it's really common, but the thing is, you'll see a lot of women just walking around who have arthritis and aren't bothered by it. So they're very fortunate. Stay away from the hand surgeon. But for those who do, studies show by the time you're 60 or 70, 60 or 70% of women have arthritis, but I don't see them.
Okay.
I'll see maybe 5% of those. And then they tell me, I tell patients, I never tell them you need surgery, they tell me.
Okay.
I have lines in the sand, the brace line, the injection line, the surgery line, and they cross the lines.
Do you think if they knew what you knew, that they would all do it? That they would, I'm talking about they've exhausted everything else, that they wouldn't put it off, that they would, especially if it's painful in the thumb, arthritis?
After I explain things, they often will make a plan to do it.
They say, okay.
But the good news is you can wait. You can wait till next Christmas. You can be a teacher and wait till the summer break. It can, and you can say, it's killing me now, and I'll give you a shot. That'll last you 3 to 6 months typically.
Okay.
And then it'll start bothering you and you'll be ready for surgery and according to your own schedule. So you can plan your kitchen remodel. You can plan your thumb arthritis. It isn't like a broken bone where you got to do it today.
Okay.
It's an elective procedure.
We are completely out of time. Final message, somebody watching this, and they've heard what you had to say, and maybe they've tried the brace, they've tried the anti-inflammatories, maybe they've had injections, but they've never actually spoken to a hand surgeon, and they're afraid for whatever reason. What do you say to them?
Well, you can tell I like to talk, all right? Education is the most important thing
So you invite
for
them
patients. You want them to come in. They don't have to, they're not wasting my time if I don't do an operation. I'd say 10 to 15% of the patients I see end up with surgery.
Okay.
For all problems.
Well, good.
So it's about counseling and understanding and having the patient be a team member in their own care and making decisions with them, not for them.
So come in with a consult, and they get to see you?
Absolutely.
All right. Well, I want to thank you for coming to the show. Good stuff.
Thank you, Randy.
Sorry to rush you, but it was really good stuff. So if they want to make an appointment, they can talk to their primary care physician, or they can call you
the
directly.
office directly. Never a problem.
Good. All right. Thanks.
All right. Thank
Good
you.
stuff. You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.